we're going to now talk about one of the most common form that keratoconus patients are aware of, and that is a non-surgical intervention, which is by way of contact lenses. And contact lenses has a very unique place in managing keratoconus patients because it can be done before or after any type of approach that you will hear, any type of management approach that you will be hearing throughout the day. So there's not a limit in terms of if you didn't do well with contact lenses, that does not preclude you from wearing contact lenses after a certain type of intervention. So it has a very unique place that it can be repeatedly tried, especially with some of the advancement in contact lens technology that I'll briefly discuss today. So Dr. Tannen had talked about the fact that your eye is very similar to a camera, and largely that is true. But I will, I'd like to go one further step and say that if anything, it's at a very minimum a sort of digital imaging processing system rather than a simple camera. So instead of just having light energy interacting with your tissue and making an imprint of an image, such as on the film or on the back inside of this eggshell, as you see, your eyes is more than just this type of simple camera. Simply because as the image enters the eye and meets its first interface, and that is your cornea and then the lens where the cataract can occur, combined together is the two major power component of your eye. If the power is correct, then the light rays are being focused into one single point, as Dr. Tannen has shown you in his presentation. Then a chemical signal or neural signal is stimulated by the nerve fiber layers in the back of the eye where the retinas are, and then it goes, this is the optic nerve, and like a cable transmits the signal to your visual processing center, and that is your visual cortex in the brain, and an image is interpreted. So all those components needs to be healthy for you to be able to see or at least maximize your visual function. And obviously the first interface being your cornea is one of the most important elements in your vision. And the vision, actually, the image produced is actually upside down in your retina, and then is corrected by your brain. So that shows you that at the very least there's some processing that is going on in your brain that reverses the image back for you. So it's not as simple or as, pardon the pun, black and white as people think that, oh, I put on glasses or contact lenses and my vision is whatever's the bottom line that I can see on the chart. Those aren't usually although those are very important to patients and doctors, those are not the only factors that we look at. We also need to pay attention to the visual efficiency and the health of the system, as well as other aspects of your vision that we can take care of once we give you back the potential to see the best possible. So for example, simple collage or collection of lines in black and white colors. Some people will see a young lady, some people will see an old lady. It just depends on which way your brain, and once I said it, you can sometimes see both and sort of revert back and forth. But it just depends on how your brain is interpreting. So that shows you that, again, it's not just a simple camera. Your brain and your eyes work in sync, and everything in your eyes needs to be healthy, starting from the cornea. So another example that nature's wonder may look sort of like a very extraordinary looking caterpillar. It's just a silly group of birds that don't understand the definition of personal space, right? So again, it shows you that it's not a construct of optical illusion. It's just that's the way your brain interprets vision. So vision, we need to get further away from just asking your doctor or wanting to know what line you're looking at or you're reading. That really isn't the only factor that is important here to your quality of life. And also keeping in mind that most targets, such as street signs, in real life is way bigger than the very bottom line of the chart. Of course, now that I said that, the advent of iPhone and the electronic devices, and we're all looking at very, very small screens, sort of wipe that scenario out. So I say get the biggest screen you can and make things as big as possible. Another scenario where no matter which spoke you look at the center, you'll notice that there's movement on the other spokes or other color pattern, even though this is a still picture. So again, it's just using colors and shape and pattern to fool your brain in terms of interpreting vision differently. So again, just want to show you that vision, you will need to think beyond what you're reading in the chart or on the chart. So really then, sort of a little bit more similar, rather than a camera analogy, a little bit more similar to maybe like a satellite TV, right? So you have your signals, which are the light rays coming towards your eye. You have all these signals bouncing around satellite and being sent towards your sensor, that being your cornea. If the shape of the sensor or the sensitivity of the sensor is accurate, so if your cornea, the shape is good, whether with a contact lens or without, then a proper signal strength will be transmitted through the series of cables such as your retina, your nerves, your optic nerve, going towards a receiver, which is your visual cortex in your brain, and then interprets, senses image back for you to, and interprets and come out with an image such as the one on the TV screen here. So if the visual signal is very weak, such as in very snowy, stormy weathers, you'll see a lot of statics on TV. That's what we're calling visual noises, because the light rays are being bent differently by the cornea and therefore unable to form the best possible signal strength to have that sent to your brain. And you've seen this picture from Dr. Tannen's, similar pictures in Dr. Tannen's presentation, in that as the shape of the eye changes and bulges forward and distorts, more and more defocusing, or because of the power difference in different area of the eye, it's going to send the image in the back of the eye to a different location, and therefore causing the ghosting, the glare, the double vision that people talk about, which really is ghosting. It's not true double vision, and start bursting and all that kind of thing. And I'll show you examples of what that look like. So technically, if you look at the side profile of someone's eye, you can see that this is a little bit more distorted and this area bulges forward compared to where an eye without keratoconus is more smooth and round. So what happened again is just to show you that if the light ray comes at the cornea, because different power due to the different curvature and different shape of the eye, all the signals are going to arrive at the back of the eye in different time. And therefore, it's very confusing for your brain to never be able to capture a still image in full. Whereas if it's smooth and round, whether or not it needs glasses or some sort of soft contact lens prescription, everything will arrive at the same time in a straight line so that there's proper strength signal going to your brain. So we know that these higher order aberration, or the visual static, visual noises that we've been talking about, is one of the main reasons that the keratoconus patients needs contact lenses, as well as why they have a decline in their visual function. So it's been estimated that these noises are about 5.5, almost 6 times more in keratoconus patients versus people without keratoconus. And although it's, and as I've alluded before, it's one way that we use to diagnose and monitor a patient with keratoconus. But possibly if we could make some more advancement in this technology, potentially we can use this to create contact lenses to also help patients who are happy in their contact lenses but potentially need to strive for better vision. And we'll talk about that in a little bit later. So some common symptoms that patients encounter with keratoconus, and I like to show you images just because sometimes family and friends, no one's looking through the same set of eyes, and therefore it's very difficult to understand why those symptoms are so symptomatic or create such barrier to having proper or good quality of life. So glare is a very common one, and that just means that everything sort of is in a fog, or it washes out the contrast, it's hard to see through. Halos, usually in a circular form or surrounding it. Typically all these are light phenomenons because again light rays is what carries visual information. And imagine how much light, especially in New York City, right? How much light we have around us day and night 24/7. It makes it very difficult and it's a huge headache for patients with keratoconus to have to leave their home and maybe leave the darkness of their room if they don't have proper contact lenses or proper corrections. And you can see it's very difficult to see that license plate because of the halo, and this isn't even that severe in terms of that, halo or glare in terms of magnitude. And star bursting, which is usually just a spoke-like pattern or radial dispersion of light because again, multiple images are being projected at the same time in the back of the eye and most of them are not in focus and therefore just creates this star bursting pattern. And you can see that the the sharpness of target goes down as glare and starburst starts to interfere with your visualization of these numbers or these images. So how detrimental can it be? Because it just sounds like words, right? Halo, glare, starburst. It doesn't sound that bad. Well, it's bad enough that you probably didn't see that person standing next to the car, right? So it explains why a lot of patients don't want to drive as soon as the sun goes down. And unless you, like Dr. Tennant say, unless you maybe live in the city and don't ever need to drive at night, and maybe so there certainly is a geographic difference of different people complaining at different things, but in most areas where your mobility, your driving is so important to your independence, that this can create a huge barrier for patients where they're just going to school, seeking work opportunities, or maybe just to live a life. Double vision, again, not true double vision, but you'll notice that if you try to stare at one of the pictures, you're rather uncomfortable. And that's because your brain is now trying to figure out why it's seeing something that it doesn't think should be there. So the mental energy that you have to expend to try to interpret your vision can be very tiring and therefore can lower one's work productivity. So it's a very real issue. It's not just, even though on the outside, externally, there may appear to be nothing that you can observe to be, say, a disability or handicap, it actually is something, it's such an important sense in our life. That's how we learn, largely through vision, that it can be something that is very tiring and very time-consuming and energy-consuming, more than we think. So maybe you just walk through life thinking that you're sitting at a 3D movie theater without anybody ever handing you the 3D glasses, right? So you can never make out whatever's on the screen that other people are oohing and eyeing. Or maybe you're an athlete who doesn't know which ball to kick, or think that you're somehow a superhero and playing against multiple teams when everybody's just playing against you. Or maybe you're paranoid and think that there's always people following you, you're not sure why, just like that Dora fish in Finding Nemo. Or just simply that you don't want to go out now that it's Christmas season. Everybody wants to go to Rockefeller and look at the Christmas tree, and you're just so bothered by it. Maybe you even have migraine that is set off by these type of life phenomenon that you don't ever want to leave your room. So regardless of what symptoms that you're experiencing, we know if we look at surveys and medical literature that the quality of life, which is what QOL stands for, is much lower in keratoconus patients. Even if it's early mild stage where you're still the proverbial 20/20, which everybody sort of want to be. Again, I encourage you to stay away, to try to go away from thinking you have to reach a certain line. We have to start being more aware of the quality of your vision rather than just quantity. But we know that even at very early stage when people can still, that's where the regular astigmatism and the irregular astigmatism sort of overlaps and becomes very confusing to know at what point does somebody actually have keratoconus. We know even at that stage, people still report that their quality of life, their perception of themselves is much lower, and it declines with time. There's a study that followed 1,209, so 1,209 patients for over 8 years, and has found that over 7 years period of time, without any intervention, such as cross-linking, such as intacs, that Dr. Hirsch is going to talk about a little bit later, such as corneal transplant, that Dr. Constead is going to talk about a little bit later. Without those type of surgical intervention and without contact lenses, it naturally will decline with time. And so it's something that's very important to control as soon as we can. And certainly it's been reported and a very common knowledge that with contact lenses, quality of life definitely improves. There's studies that show that people with keratoconus, KC, in contact lenses have greater quality of life compared to keratoconus with no contact lenses. However, still less than people who have no keratoconus in the control group wearing contact lenses. So that means that we should continue to strive to bring about better technology in contact lenses, because we know that probably due to the higher order aberration, the visual noises, that even despite the best fitting lenses, there's definitely a small group of people who still continues to not function or see as well as those without keratoconus. And there's a paper that actually discussed that different type of lenses, whether it's a custom soft lens or a gas permeable lens, aka hard lenses that we just discussed this morning, or hybrid lenses, and certainly there are other category of lenses that, as long as it's properly used, properly selected, quality of life improvement is very similar, proving to you that there's no one best type of contact lens. Because I get asked that a lot. Before we delve into different type of contact lenses, the first question I get asked, whether by resident, other doctors, students, or most importantly my patients, is that what is the best contact lens? I want that. And the answer is there's not one that's best, because many of them can work depending on your goal, depending on your lifestyle, depending on exactly what your previous experiences are and the skill that you have in handling contact lenses. Are you able to put in a large lens or a small lens? All those things are important in my mind when I'm selecting contact lenses. So certainly it's important for you to openly communicate with your eye doctors, whichever specialist you're seeing, to take care of your contact lenses. But it's been estimated also, there's a paper in ophthalmology that reported in 2013, just looking at Medicare beneficiary alone, those with eye diseases that qualify them as low vision, and certainly not just keratoconus, all eye diseases, cause indirect health costs. That is, maybe they injure themselves due to the lower level of their vision and needed to go to emergency room or need to seek health care, cost the taxpayers about $2.14 billion. And that's just in the Medicare beneficiary in 2013. And that proper fitting of contact lenses have been found to have a benefit ratio possibly, and with a report to have economic gain of about $10,000 a year. And obviously you can't put a dollar sign, I think in my mind, you cannot put a dollar sign on somebody's quality of life. So even though this is very nice that you can have huge benefit from getting proper treatment and management, I think we need to take each patient as individuals and try to make their life scenario and circumstances as best as possible. So what do contact lenses do? How come that is the primary option for keratoconus patients versus something, say, like corneal transplant? Or other type of procedures that we will be discussing today. Well, it's because contact lenses has a very unique ability to, when it's being placed on the eye, the outer shape of the lens, the better that it can keep that outer shape, the higher its ability to reform the optical system at the front. So in other words, it's like a second skin. If you were to wear a glove to block a burst defect on your hand, if you put a contact lens on, the contact lens mask and cover up the keratoconus distortion, and the outer surface of the lens now act as your cornea. And whenever you remove the lens, the effect is obviously not there. Whenever you put the lens on, the effect comes back again. So it also has a benefit of being able to show you in the exam room what your vision is going to be. It's reversible, as in if you don't want to wear the lens, you get to take it off anytime you want. So it has numerous benefits. It's not without work from patients to try to get used to the type of lens that's being fitted to their body, but it can have tremendous benefits once you get used to the contact lenses. So I think that all these goals are very important, but for me, if I can only pick a couple goals to say, we at least at minimum need to get to this with specialty contact lens fitting, I want the lens to be able to sustain and maintain proper cellular metabolic exchanges so that it maintains the health of the eye, as well as good, even and as gentle as possible, very low amount of pressure distributed over a good area, so that the possible trauma or shearing force and from the weight of the lens is not directly being placed on the most fragile part of your cornea. And that actually is one reason why there's so many different technology advancements since gas permeable lenses or hard lenses, because being that it's the smallest lens in the family, it tends to place more pressure on the part that bulges out the most, and that tend to be regarded as the most fragile portion of your cornea. So because the glasses is sitting in air on the bridge of your nose, it has no ability to reform that outer shape, and therefore if you have no keratoconus, you may be able to see like this with keratoconus. Unfortunately, with glasses, you're seeing in the outer area where it does not really, because it doesn't change the geometry of the outer surface, it's not able, in most circumstances, not all, early keratoconus patients are able to see pretty well with their glasses, that's for sure. As soon as a certain stage is reached, it is difficult to recover or restore vision with glasses due to the fact that it's sitting in air, not on the eye. So this is the distribution that I was talking about. Rather than have all weight being bared onto one point or very small area, it's much better to, you can see the impact to the ball. Obviously it's not fair because one's a bigger elephant, one's a smaller elephant, but ignore that. It's just, the point is you can see what it's doing to the, and imagine that being your eyeball, right? So it's very important to actually pay attention to that as well. And that alone can explain some of the burning and itching, stinging sensation that this gentleman was talking about because of the pressure of the device that you're wearing. So that's why I say it may depend on what type of lens you're using. So let's talk about the general category of contact lenses. So let's talk about gas permeable lenses. So the benefit that I typically see with gas permeable lenses, again, it's being that it's the smallest type of lens in its family. It actually comes, although with a little bit more focused pressure distribution towards your cornea, like I've talked about, which sets up a situation that it requires longer period of time for adaptation, because your cornea is very sensitive, whereas other parts of your eye, including the white part of the eye, your eyelids are not as sensitive as your cornea. So a small lens that has more weight distribution onto your corneal tissue can be a little bit less comfortable, maybe even more irritating at the beginning. However, because it's smaller, it's very easy to take care of. It's a harder lens material, so it doesn't break easily. So the carrying of the lens is very easy. The handling of the lens, as in the in and out of the lens, is very easy. It's a smaller lens that doesn't have a huge amount of adhesive force onto the eye. Therefore, you see, even in either support group or from other people, or in movies where people look for their contact lenses, because it's the smallest lens with the least amount of adhesive force, so it can come off quite easily, especially if it's not fitted properly. So that's why that is a possibility. However, it's very durable, it's less expensive cost-wise compared to other lenses because it's been around the longest period of time. And so those are the pros and cons of this type of lens. And most people, who again ask me sometimes they ask what lens is the best, sometimes they say, could I just wear a soft lens? Well, as I've explained with a similar analogy to glasses, if the material is not able to intimately surround your cornea and also maintain its outer shape, it's going to be less effective in improving your vision. Therefore, soft lens, being that it's a softer material, most designs are not able to maintain its shape as well, and so it still let the keratoconus outpulging shape that will show through. Therefore, it's a little more difficult to improve someone's vision. However, in the last 3-4 years, we have custom keratoconus lenses that is made in a soft lens material now, and sometimes it comes quite close to the level of vision that people are able to get compared to the gold standard of gas permeable lenses. And they're typically made a little thicker, it's a little stiffer nature material probably, and therefore it maintains its shape much better compared to a regular disposable soft lenses that's not meant to last long, so there's not a whole lot of material being invested into that type of disposable modality. And it has very high range of prescription that can be made from, as well as shape compared to a disposable lens. And therefore, it maintains the characteristic of a soft lens in that it's still very easy to put on, still very easy to take off, a little larger than the gas permeable lens, so one can argue that a gas permeable lens is even easier for somebody who's very anxious in putting something on their eye. And the disadvantage is that typically it just isn't the most effective way of improving one's vision, because that material has much more flexibility. Even though that may be perceived as more comfortable, it's not able to maintain its pure optics throughout the day. But again, for some people, that's a blessing in disguise when when they are choosing between cannot see at all to seeing 70-80% for the whole day. So that can be a good tool to use pending the patient's reality and their goals. Piggyback lenses, if we want to maintain the level of vision that one can get with a gas-permeable lens, but however cannot adapt to the way the lenses feel on the cornea, no matter what kind of design is being used and technology, new technology and feature being incorporated into a gas-permeable lens. Well, somebody came up with a really smart idea calling it piggyback lenses, which we cover your cornea with a soft lens acting like a bandage or a cushion to absorb the weight distribution from the gas-permeable lens. And now that we have tons of different soft lenses that we can use that are more breathable, that allows more oxygen through, it's not, at least it's much less of a concern when you double up on two lenses in terms of slowing down the rate with which oxygen is being delivered to your cornea. So a lot of these new soft lenses that are much more gas permeable as well makes this type of system work even better. So obviously better comfort because the cushioning factor compared to a gas permeable lens still maintains I know it sounds crazy that you're putting two things on the eye. If you don't even want to put one thing on the eye, I completely get it. But I will tell you the number of patients who come back and say, you're so right. I imagine it to be much more involved system, in sort of not paying attention to the fact that there are both lenses very easy to put on, both lenses pretty easy to take off. And therefore, it doesn't add more than a minute to your routine at all. Although mentally, we always think that sounds much, much more involved. So the advantage is once you get used to it, it's better comfort. It actually is very easy to take care of. Still very easy to put on and take off. You just have to do it twice on each eye. But that perceived complexity for most people can be a barrier. So that may be one disadvantage too. And of course, you have to watch the cornea to make sure it's getting enough oxygen, and therefore that may be something that you have to work with or work on with your doctor. So since that if the putting on two lenses is something that intimidates you, then there's always an inventor in the crowd, right? Someone else came up with the idea, well, why don't we just bind the two lenses together? Not just put the gas permeable lens combined with the soft lens. It's a very complicated technology, but we are now making it work. And so that patients only put on one lens rather than multiple lenses. And wouldn't that be good? Of course. So it's again, everything has pros and cons, so I want to be honest with you. I want to give you my take on what the strength is and the weakness is with each lens family. And each of these families have many different lens designs. I just want to make sure that you know, most of these lenses have multiple and different designs. Usually it's not just one lens or one manufacturer. So the newer lens technology, let's go back. These newer hybrid lens technology incorporates very breathable materials, so again maintains that gas permeable characteristic much better than a couple decades ago when we first tried hybrid lenses. And most practitioners and specialists still have the mental picture of the type of patients that we fitted 10, 20, 30 years ago with hybrid lenses when they, in the long run, have encounter issues with not getting enough oxygen. These lenses are no longer the same design. They're much wider parameters. They fit much, much better, and they're more gentle on the eye. And I put a color solution in the lens just so you can see at the inner circle where the green portion ends is where the gas permeable lens is. There is a black, you sort of can see a very faint clear or black line right here. That's where the soft lens ends. And the fact that the soft lens can contact the white part of the eye, which is not very sensitive, so able to reactively use that as a support area and push the gas permeable lens away from your cornea, therefore relieving that pressure distribution on the sensitive portion of your cornea. That is why a hybrid lens can be more comfortable than a gas permeable lens, especially combined with the fact that you can store fluid, preservative fluid, hopefully, because that's friendly for the eye and it's good for the health of the eye. Being kept underneath the lens all day long, it actually can even have a little bit of anti-desiccation or anti-dehydration effect to the eye. So it makes the lens very comfortable to be worn. However, because you have to fill fluid into the lens and have to balance the lens at insertion, that may be something that you have to learn how to do that. Some people do that like fish in the water. Some people need a little bit more time. So again, we need to match each lens to each patient. In my mind, there's not one lens that is best. And here you see these hexagonal shape are intact devices. This is your cornea, and Dr. Hirsch will talk about intacts a little bit later and how it can change the shape of your cornea to potentially make the lens a little bit easier to fit. This space right here is the fluid that you put in to bathe your cornea and make the cornea comfortable, and this very outer surface is the shape of the hybrid lens. And therefore, when the light interacts with the lens, it fools the light into thinking that's your cornea, and given proper power, given proper shape, that's how your vision can improve in a keratoconus patient. And this is just a comparison to show you that what we have in a hybrid lenses 20 years ago is no longer the same as what we have now. Scleral lenses, a lot of people have heard of that. So sclera is the white part of the eye. Scleral lens is a lens that's large enough to utilize even more of the white part of the eye, just like I pointed out with a few minutes ago, a moment ago, on hybrid lenses where the soft lens is covering the white part of the eye and then able to push your gas permeable lens or the weighted component away from your cornea. Well, scleral lens can do the same, and probably and even better in that because it's larger, it can have a more fluid space to bathe your eye to make the eyes even more comfortable. And it has many different variety of uses, including treating people with autoimmune disorders with tissue destruction on the surface of the eye, to people with no keratoconus but have very dry eye that needs that extra fluid when hybrid lenses is not providing enough. Again, as the lens gets larger, though, if more patience at the beginning in learning how to hold your eyes wide open, putting the lens on. It is a very comfortable lens because of we're fitting the anatomy of catering to the white part of the eye. That certainly is true. And there are different fitting platforms that are advancing, such as using a computer to trace the white part of the eye. That's something that we were never used to do. So it's difficult to predict what kind of fitting you have to put in these scleral lenses. There's new computer system out there. In my mind, will get better. I think that technology will mature, but in scanning, using a special instrument to scan the white part of the eye, we're able to then utilize the data in the lab to replicate a lens, or an impression material as something that is very easily teased apart from the eye. It's sort of like creating a mold for your eye. That has been revived in a much friendlier way to make an impression and a mold of the shape of your eye and the white part of the eye, and using that to trace the shape of the lens that needs to be produced. Again, I think the technology will mature, and those are probably there was a very new technology that potentially, if somebody cannot get used to any type of lenses that they've tried, that's possibly something that can be tried as a last resort in terms of scleral lenses. So before we end this session, what kind of fitting challenges do people face? I've talked about the pros and cons of each lens category. Well, you know, your tear is even though I talked about cornea as the very first interface that interact with light, it actually is your tear, and your tear covers your cornea. So whatever shape your cornea and tear makes is what your natural shape of your eye is. So if you now introduce a contact lens that needs to sit and be bathed by your cornea, by your tear, if your eyes are dry and you don't have enough fluid to supply the lens and maintain the hydration level of the lens, that lens can dry out. It can become very uncomfortable, and therefore we need to treat concurrent conditions that is happening on the eye at the same time, and it can also decrease your vision. This is the simulation with a soft lens. This on the top image is a lens that is freshly inserted and one that had dehydrated. So you can see that definitely there's some blurriness even in a soft lens. From these type of simulation. Ocular allergy, we talked about it, and Dr. Chu talked about it. You can rub anything out of the eye, you know, any foreign body that you put in the eye, you can rub it off. And so therefore we must, and also if your eyes are itching and red and tearing due to seasonal or perennial allergy, it certainly makes it very difficult for you to want to get up and put another device on top of your eyes. So again, need to discuss that with your eye doctor and and have that under control. And something that most people don't think about, your care solution, the type of material that is made in the contact lenses and the type of solution with or without preservative that you use to condition and take care and disinfect of your lenses, those remnant particles can also cause irritation to the eye. Those who wear gas-permeable lenses and inadvertently have put cleaner fluid into the eye knows what I'm talking about, right? So that's also something very important. I design, what over-the-counter type of combination that each of my patients use. So it's not, again, one solution fits all. It's not one contact lens fits all. Everybody have sometimes just need a different combination of management approach. And lastly, again, I talked about the fact that some people with keratoconus still with the best fitting contact lenses do not feel like they see as well as their counterpart with no keratoconus. So we know that to be true. And so maybe additional customization that we can make and advancement in new technology can make a difference there. And that is, we talked about the wavefront analysis during my opening speech, and that is the instrument that measures the visual static or visual noises created by your cornea. If we can use that, in which it's being looked at right now as we speak, this is the amount of visual noise is very little. You can tell because it's pretty even colored. This is a keratoconus patient. You can tell how the top portion is very different from the bottom portion. And if we're then able to use this data, put this in a contact lens so that we can make an opposite pattern on the contact lens, then we can perhaps, quote unquote, perfectly correct someone's vision. We're still a ways from that yet, but that is a possibility. So that's something that, of course, I am looking forward to. And so, open communication with your doctors in terms of your life goals and your expectation with what you would like to get out of your fitting, as well as committing the time. It's not like you're friends with regular astigmatism or just with no keratoconus. They get their soft lenses and they're done in one visit in 10-15 minutes. It's not that. You, apart from wanting your doctor to give you the most amount of time to give you the best care possible, you in return also need to commit to the time process that it may take to get to the best device that can be made for your eyes. Because some people come in there in a rush. They think that this is one visit. We see a lot of people out from different country. They think that they could just leave the same day. It doesn't really work that way. Custom lenses take time to make as well. And as your life changes, even if you are doing really well now, maybe you don't need reading glasses. Maybe later on you need that incorporate into your contact lenses, or you need to know what proper glasses to wear on top of your contact lenses. So that's certainly, as your need changes, as you go enter different phase of your life, that can change. And I want to share with you very quickly about the result that we did with our clinic in looking at 329 eyes of people coming in for consult, those patients with keratoconus. You can see that those who continue to be refitted with contact lenses report a higher level of contact lens tolerance. That is, they're comfortable enough. Maybe they're not happy, but they're comfortable enough to wear their lenses for a few hours a day. They have, those who don't go towards surgical intervention have much higher level of tolerance, and they get very good level of success after being tried the best type of contact lens I can come up with. And those with very much lower tolerance to contact lenses, they cannot even put the lens on for more than, say, or at all, or more than an hour. We tend to manage them with a different surgical option that Dr. Hirsch is going to talk about, stabilize their eye, make the shape of the eye better. They come out to also have very good success, and maybe one can argue is slightly better. And that may show you that there's synergistic effect in doing combination approaches of changing the shape of the eye with the surgical mean, try to make the shape of the eye better, and then fit the patients with contact lenses. So in conclusion, contact lenses can be tried before or after any type of surgical management and continues to be a very effective way because it's practically the only way that we can really reform the outer surface of the eye while being able to simulate to you what kind of vision a keratoconus patient is going to get. And also just understand that combination approaches with surgery may complement the outcome of a contact lens fitting should you fail the first try. And obviously be open to all different type of lens options and the recommendations from your eye doctors, and that there's not one lens that fits everybody. So that is the end of my presentation. Thank you very much for your attention.